Hello everyone, today I'll present about drug profile of menotropins, a fertility medication. Firstly, menotropins are a combination of two hormones, follicle-stimulating hormones and luteinizing hormones. They are also known as human menopausal gonadotropins or HMG. In terms of classification, pharmacologically they fall under gonadotropins, therapeutically as fertility agents, and they are categorized as group B poisons. The mechanism of action differs slightly between females and males. In females, the FSH part promotes follicle growth and estrogen production, while LH supports follicle maturation and triggers ovulation. In males, FSH helps mature sperm and LH stimulates testosterone production, supporting sperm production and libido. Clinically, menotropins are used for ovulation induction, especially when first-line treatments fail, control ovarian hyperstimulation in assisted reproductive techniques, and in males to treat infertility caused by hypogonadotropic hypogonadism, usually combined with HCG. Now, let's look deeper into the pharmacokinetics. Menotropins are administered via subcutaneous or intramuscular injection because they are not orally bioavailable. This is because they would be destroyed in the gastrointestinal tract. Once injected, they are well absorbed into the bloodstream. The hormones bind to FSH and LH receptors on target cells. Being glycoproteins, menotropins do not cross the blood-brain barrier and don't easily enter cells, so they act mainly on the surface receptors. They are metabolized gradually by enzymes in the liver and kidneys, breaking down into smaller peptides and amino acids. These components may be reused by the body or further broken down. Finally, the metabolites are eliminated through the kidneys. The intact hormone isn't excreted, and only the inactive fragments are filtered into the urine. In patients with severe renal impairment, dose adjustment might be necessary.
Now we'll be going through essential patient counseling points for menotropins. We will cover how to use it, therapy duration, possible side effects, precautions, interactions, and proper storage. Menotropin's dosage varies based on the treatment goals. For ovulation induction, the usual dose is 150 IU daily and may extend up to 20 days. In ART procedures, dosing starts low and is adjusted by response. For male infertility, is combined with HCG and used at least 3 months. Always follow your doctor's instruction closely. Menotropins are given either subcutaneously or intramuscularly. Subcutaneous injections are done in the abdomen. Clean the site, pinch the skin and inject. Intramuscular shots go into the upper outer thigh or buttock. Don't forget to rotate injection sites and monitor for any irritation. Therapy length depends on your response and treatment goal. Ovulation induction may last up to 20 days. ART follows your cycle closely. Male infertility therapy takes a few months. Regular monitoring is important to avoid overstimulation or complications. Menotropin therapy requires regular blood tests and ultrasound to prevent serious side effects like OHSS. Longer or higher dose use can increase the risk of ovarian cysts, multiple pregnancies, and blood clots. Stop treatment if you experience severe pain, rapid weight gain, shortness of breath, or unusual swelling, and seek medical help immediately. Common side effects include abdominal pain, nausea, bloating, and injection site reactions. More serious ones like OHSS or blood clots need immediate medical help. Rare effects include ovarian torsion or multiple pregnancy. Always report unusual symptoms and never skip follow-up visits. Menotropin should not be used if you have allergies to the drug, hormone-sensitive cancers, or pituitary or hypothalamic tumors. It's also contraindicated in primary ovarian failure, abdominal bleeding, or uncontrolled endocrine disorder. Avoid use during pregnancy or breastfeeding, and if infertility isn't caused by ovulation problems. Use menotropins only under specialist supervision with proper monitoring. Evaluate the male partner's fertility too. Patients need ultrasound monitoring and should avoid sexual activity to reduce risk of multiple pregnancies. Be cautious if there's a history of organ disease or allergies and avoid driving until you know how the drug affects you. Avoid mixing menotropins with alcohol or other fertility drugs unless directed. Share a complete list of your medications and supplements with your doctor to avoid any interactions. Store menotropins in the fridge or at room temperature, but never freeze them. Use the mixed solution immediately and dispose of needles safely. Ask your pharmacist if you have any doubts about preparation. That's a wrap on menotropins counseling. Always follow your healthcare provider guidance and don't hesitate to ask questions during your treatment journey.
So now we're going to talk about Follitropin. We'll cover about the description, classification, mechanism of action, indication, clinical uses, and the drug pharmacokinetic. So what exactly is Follitropin? It's a drug that acts like a natural hormone in our body called follicle-stimulating hormone or FSH, which help in the development of eggs in ovary. This drug can only be given to a patient with a prescription from a doctor. It is used to help with reproductive issues such as problem with ovulation, issue with egg development, and even low sperm count in men. Now we'll look into Follitropin classification. In terms of what it does, it belongs to the gonadotropin group, while from a treatment perspective, it's considered an ovulation stimulant and infertility agent, meaning it helps to stimulate ovulation and treat infertility. While in general it is grouped into tropic hormone and related synthetic drug, and finally for regulatory purposes, it's classified as a Group B drug. Now how does Follitropin actually work? When Follitropin or FSH connect with a specific part of a cell called a receptor, it kicks off a reaction inside the cell. This process involves something called phosphoinositide 3 kinase, or more known as PI3K, which will send signals that help control many important body functions and keep the cell healthy and alive. Follitropin has some crucial use for women. It is often used along with another hormone such as HCG to help with ovulation and fertility, especially in those who have primary ovarian failure. And for men, Follitropin helps in the production of sperm, particularly for those with a condition called hypogonadotropic hypogonadism. This proves that this drug is a key part of assisted reproductive technologies such as GIFT and IVF, which will help women to produce multiple follicles for egg retrieval. Let's dive into how our body handles Follitropin. When it's given as an injection under the skin, it's absorbed fairly slowly. Its availability in the body is about 66 to 76%. It typically reaches its highest level in the blood between 8 to 16 hours in female and 11 to 20 hours in male. Once absorbed, Follitropin is distributed to the ovary and the kidney, just like the normal FSH do. Now, while there isn't extensive research on its metabolism specifically, it's believed that Follitropin or FSH is broken down in the kidney and liver. And for excretion, it's mainly removed from the body through the urinary system, but some of it also exits through the pathway in the liver.
Now we are moving to Follitropin's patient counseling. Follitropins are fertility medicine. In women, they help eggs grow, while in men, they support sperm production. Knowing how to use them safely is important. They are given subcutaneously under the skin, usually in the belly, thigh, or upper arm. Always clean the skin, inject straight in, and dispose of needles safely. For women with anovulation, including those with polycystic ovarian syndrome, the dose starts slow and may be increased based on response. Regular scans and hormone checks are needed. In IVF or assisted procedures, the starting dose is higher. The doctor will adjust it based on ultrasound and blood test results. For men with hormone-related infertility, Follitropins are given after HCG 3 times a week. Doses may increase if needed. Semen analysis and hormone levels will be monitored. Treatment lasts until eggs are ready in women, usually 1 cycle. In men, it may take up to 18 months, and if there is no progress, the dose or plan may change. Serious side effects include allergic reactions, ovarian hyperstimulation, blood clots, and breathing issues. Seek medical help if these occur. Common side effects are headache, mood changes, stomach discomfort, and injection site reactions. Women may feel pelvic pain, while men may have breast swelling and lower libido. Less common side effects include cold symptoms, sore throat, or reduced sexual desire. Some side effects may improve over time. Regular monitoring is key. Women need scans and hormone tests, and men need sperm and hormone checks. Do not use if pregnant,
breastfeeding, or if there are certain hormone problems, tumor, or unexplained bleeding. Use with caution if there is a history of blood clots, tubal disease, or porphyria. Always mention any allergies. Some medicine reduce Follitropin's effect or increase side effects. Tell your doctor about all medications and supplements. Store unopened vials in the fridge or a cool place. Once opened, keep below 25 degrees Celsius and use within 28 days. Follow instruction carefully. In summary, both menotropins and follitropins are effective in treating infertility for both men and women. Menotropins provide both FSH and LH ideal for dual hormonal needs, while follitropins offer high purity and consistent results, especially for ART procedures. Both require proper counseling, injection training, and close monitoring for risks like OHSS. Follitropins are preferred for high purity FSH needs, while menotropins suit patients needing both FSH and LH. Drug choice depends on patient factors, cost, and clinician judgment. Pharmacists must stress correct injection, storage, and early reporting of side effects.